good morning, everybody. Thank you for being on this episode of Meet the Meso Experts with me. Today, we're very happy to have Dr. Marjorie Zotter from Sloan Kettering and Dr. Erin Mansfield from the Mayo Clinic. We're going to do an overview today of immunotherapy, where we're at, and kind of where we're headed. So we will have a question and answer at the very end, but I'm going to kick it over to Dr. Zotter to go ahead and start with your presentation and introduce yourself, please.
Thanks, Shannon. I am a thoracic medical oncologist working at Memorial Sloan Kettering, and I have a focus on mesothelioma, and some of you maybe I know already, some don't. And I'm just going to give you a little bit of an overview about what immunotherapy is, and then hand it over to Dr. Mansfield to delve into some of the data around some of the treatments that folks may be receiving. And I'm just going to pull up my slides real fast. So these are my personal disclosures as they relate to any commercial entities for research funding and speaking and consulting. So for a high-level overview, I wanted to talk about what immunotherapy is. So when we use the word immunotherapy, it really refers broadly to any type of treatment that uses a substance to help stimulate or suppress the immune system to help the body fight cancer. And so that can include a variety of treatments. Most of the time when we talk about this as it relates to mesothelioma, we're talking about a class of drugs called checkpoint inhibitors. And I'll explain a little bit more about what those are. But really, immunotherapy could also be vaccines, T-cell therapy, and there are actually some medications that come in the form of antibodies. And antibodies are the way that your immune system recognizes things and helps figure out if it's foreign or if it belongs there. And what gets confusing is that a bunch of treatments come in antibody form, but that doesn't necessarily mean that their mechanism of action is immunotherapy. So the example that comes up for me a lot in my practice is with the drug bevacizumab, or the commercial name of Avastin. And that's an antibody treatment, but it's not immunotherapy because it's targeting a receptor called VEGF. So you just have to be a little bit of a conscious consumer of the information that not all antibodies mean that it's an immune therapy. It's not necessarily having activity on the immune system. So how do these treatments work? And here I really wanted to focus on the checkpoint inhibitors. So the way I often explain it is that when your immune system is sort of revving up and coming online when you're a baby, basically, and you're encountering all of these new things and germs and substances your body's never seen before, it's kind of like boot camp. And your immune system is figuring out, is this safe or is this potentially dangerous? Does this belong? Is it part of me? Does it belong, but it's not part of me? Or is it something foreign and I should react and attack it? So the way the body does that is the things that are supposed to be there in our body are able to emit a signal that suppresses the immune system a little bit. And we refer to those important stations in terms of activating and turning off the immune system as checkpoints. And there are two key checkpoints. One is around PD-1 and one is around CTLA-4. This is PD-1 here on this cartoon, and this is CTLA-4 here. So PD-1 is usually expressed on tumor cells, and it's something that the tumor cells, the cancer cells, are able to express on their surface. It's a protein that tricks the immune system into saying, oh, this is supposed to be here, so that the body thinks that it's part of the normal tissues that are supposed to be there and therefore doesn't attack it. CTLA-4 similarly is on the surfaces of immune cells and can be interacted with by something on the cancer cells to suppress the actual activity of an immune cell. So the way immunotherapy treatments work is there are drugs that are designed to disrupt the PD-1, PD-L1 binding or the CTLA-4 binding with its partner so that the immune system no longer sees or is able to see the cancer cells. So the cells are no longer hidden. Again, sort of an analogy I use a lot is it's almost like the cloak of invisibility from the Harry Potter books and movies. And these drugs come in and they rip that invisibility cloak off. So they take that off, and then all of a sudden the immune system is able to recognize those cancer cells as not being present, being foreign, and therefore hopefully able to attack them. So one of the common questions that comes up is people ask, well, how is immunotherapy different from chemotherapy? So chemotherapy is really made up of drugs that stop the growth of cancer cells, either by killing them or by stopping them from dividing. And chemotherapy disproportionately targets rapidly dividing cells. And so the side effects associated with that come from damage to rapidly dividing cells. So there's a common thought that immunotherapy is easier or has less side effects than chemotherapy. And when we look at the data, and some of this is what Dr. Mansfield will talk about, immunotherapy doesn't necessarily have less side effects. So when we look head to head, the percentage of people having side effects with immunotherapy versus chemotherapy is about the same, but the side effects are really different. So with immunotherapy, the side effects and the ones that we worry about are from overactivation of the immune system. So sometimes when we give the checkpoint inhibitors, not only does that then let the immune system recognize the cancer cells, but it now starts recognizing cells that should be there and should be hidden. And so you can have an immune reaction where your immune system starts to attack the healthy and normal cells in the body. Thankfully, that happening with any severity is relatively uncommon, somewhere under 10%. But when it does happen, and it does happen with severity, it can be quite serious. That said, on a day-to-day basis, if you're not having one of these more severe autoimmune events, typically immunotherapy isn't associated with the nausea and fatigue and mouth sores and other things that can sometimes come along with chemotherapy. And I think that really sets us up great to hear about some of the data around these drugs and why we use them sometimes in mesothelioma. So Dr. Mansfield, I would pass it over to you.
Thank you, Dr. Zouderer. I'm pulling up my slides to share. As Shannon introduced, I'm Aaron Mansfield from Mayo Clinic in Rochester, Minnesota. I'm also a medical oncologist like Dr. Zouderer, who specializes in thoracic malignancies and especially mesothelioma. And I was asked to cover a few topics on immunotherapy in mesothelioma. These are my disclosures. The one that's most relevant to this is I was on the steering committee for the Checkmate 743 trial that I will discuss in the next few slides. So Checkmate 743 is just the name of a clinical trial that I'll explain in more detail. And this is the design of it. There are various stages of clinical trials where when a drug's early in its testing phase, we would call that a phase 1. And at that point, we're trying to learn a safe dose of the drug to use. After that, we often do a phase 2 trial to try to get a signal as to whether something is effective or not. And then in a phase 3 trial, we're really comparing a new drug or a new regimen to the existing standard of care to see if we should replace our standard of care. And what Checkmate 743 did is it took patients who were newly diagnosed with unresectable pleural mesothelioma, and it randomized them 1-to-1 to receive an immunotherapy combination or the chemotherapy standard of care. Now, Dr. Zauderer introduced the antibody-based immunotherapies, and in this study, 2 of them were combined together, and those were nivolumab and ipilimumab. The other names for these drugs are Opdivo and Yervoy. In academics, we often refer to them by their generic names as we do here. So in this study, over 600 patients were randomized to either receive that combination of nivolumab and ipilimumab or chemotherapy. The nivolumab is an antibody that blocks PD-1 and or binds to PD-1, and therefore blocking its interaction with PD-L1. And the ipilimumab blocks or binds to CTLA-4. So as with the metaphor you heard, what these drugs do is it removes that cloak of invisibility of the tumor to help the immune system then recognize the tumor cells and destroy them. Some people refer to it as cutting the brake line or disinhibiting them, but there's all sorts of metaphors being used, but it helps the immune system recognize the tumor cells so that the immune system, the T cells of the immune system, can then kill the tumor cells. And this was compared to what has been our standard of care for about 20 years, which is a combination of a platinum-based therapy and pemetrexed, drugs used around the world to treat mesothelioma. So in general, I am not showing the discrete data, but in general, what we saw was that the immunotherapy was better than chemotherapy. And there's some nuance to that, and I'll describe that in just a little more detail as I talk about the different subtypes of mesothelioma. So my colleague, Dr. Roden's a pathologist, and she gave me these pictures just to help illustrate what I'm talking about. But as we look at all cases of mesothelioma, the majority of them are a variant called epithelioid. Then there's a smaller proportion of patients with a variant called sarcomatoid. And then there's some patients who have both, and we call that biphasic. So Dr. Hetty Kindler at University of Chicago refers to this as vanilla, chocolate, or swirl, just to help you understand that it's one, the other, or a mix of the two. And what happened in Checkmate 743 is, like I said, overall, for the 605 patients or so who went on the trial, immunotherapy was clearly better than the chemotherapy. But then when we looked at the subtypes, we saw that the immunotherapy benefit was much greater for the patients with the sarcomatoid or the biphasic variants of mesothelioma. For the epithelioid type of mesothelioma, the survival curve for immunotherapy was a little bit better than chemotherapy, but not to the same extent. So how we've interpreted that is that for patients with the sarcomatoid or biphasic variants of this disease, the immunotherapy is clearly the approach that we favor, as long as there's no contraindications to receive it. For patients with the more common epithelioid variant, we have a little more equipoise as to whether immunotherapy or chemotherapy is the better approach, and that's a decision we have to individualize with our patients. I'm going to kick it back to Dr. Zauderer in a moment, but we're going to, when I take it over again, we'll talk about how combinations of immunotherapy and chemotherapy are being explored and how that may change practice in the future, but not yet today. So Dr. Zauderer, I'll hand it back to you.
Sure. Thanks, Aaron. Excuse me, everyone. So, the next thing that Shannon and I had talked about covering related to immunotherapy in combination with radiation and novel treatments. And I didn't put any slides for that, somewhat intentionally, not somewhat intentionally, because I really wanted to talk through that. So a while ago, when immunotherapy for any type of cancer was relatively new, there were reports about giving immunotherapy and then radiating a particular spot, let's say like a bone in a shoulder, and that spot shrinking in response to the radiation, as you would expect. But then also suddenly now having shrinkage in a different part of the body where there was a cancer spot. So there's been a lot of research, a lot of focus, a lot of conversation and interest around this phenomenon, which is called the abscopal effect. I think that fundamentally, when you look at the literature on this, it's a relatively rare event, but there's a really strong scientific rationale for why this might happen. So typically, the way radiation therapy works is it's this high dose energy beam that's aimed at the cancer spots, and ultimately, those cancer spots die. And in the process of that cell death and your body sort of cleaning them up and getting rid of them, the interior contents of those cancer cells are often released and exposed. And so if we go back to sort of thinking about how does the immune system recognize something as it's supposed to be there or it's not supposed to be there? Well, if we suddenly unleash all this other mess that wasn't out there in the body, in the circulation, in the sort of, cellular environment, there's a lot more for the immune system to react to and respond to and to recognize and say, hey, you know what, this is foreign and shouldn't be there. So there are some studies out there that are really looking at the combination of immunotherapy, checkpoint inhibitors with radiation. So with Dr. Rimner, who's a radiation oncologist at Memorial Sloan Kettering, we did a clinical trial of an immunotherapy drug called avelumab, and that was given with high dose, very focused radiation to a particular spot. And it was actually looking to answer this very question. In addition to the radiation working really well on that one spot, could we kick off more responses or responses elsewhere in the body by that combination? So that study was small, and we did not see that. We did not see that what happened to people from the combination was any better than just getting the immunotherapy by itself. And I think one of the questions you may be thinking, avelumab, what's avelumab? I've heard of nivolumab, I've heard of pembrolizumab, but I haven't heard of avelumab. Well, that's because avelumab, of all the different sort of flavors, and we do a lot of food metaphors in cancer. So we had the ice cream flavors. I often talk about nivolumab and pembrolizumab. It's Coke and Pepsi, and there's different data, but ultimately they target the same thing. Well, avelumab does too, but in a clinical trial that was run by Dr. Hassan, the response rate with avelumab was lower than the ones that we saw with nivolumab or pembrolizumab alone, let alone the combination from Checkmate 743 with nivolumab and ipilimumab. So avelumab is typically not used, but at the time we started that trial, we didn't really know that part of it yet. So the question, I think, is still a little bit open. And there are some other trials going on at our center and places around the country looking to combine different immunotherapies like pembrolizumab, nivolumab, with forms of radiation to try to figure out who are the patients where it makes a difference. And I think that thematically, from everything that Dr. Mansfield and I and Shannon are going to talk about, these drugs represent an amazing, tremendous advance in the treatment of mesothelioma, but not for everyone. And we're still struggling with our ability to know beforehand who's more or less likely to respond. And similarly, with the combination of immunotherapy and, let's say, radiation, who would respond to immunotherapy alone, where the combination is going to make all the difference. And we just don't know it. And we know for some people that's probably the case, but we don't know how to predict it, and we haven't proven that that's a fact yet. The other area that comes up all the time is the combination of immunotherapy with these so-called precision medicine drugs. And I think as immunotherapy was becoming more of a standard in mesothelioma, there was a flurry of trials where every novel drug and targeted drug was being combined with immunotherapy, and like, well, why not, just sort of do it. So I think there's, really two key reasons to combine medications. One is when there's a biologically plausible mechanism for why the combination would be helpful. So there are certainly targeted therapies where you can imagine that changing the immune environment around a tumor could maybe help that targeted drug get into the tumor, or it could change some kind of downstream expression in the cell. And those types of combination therapies, there are lots of different trials looking at them in mesothelioma, or more commonly in sort of these trials that let in any kind of solid tumor. So looking to figure out what the best combination treatment might be. I think the second reason that a lot of drugs get combined together is when they've already independently shown activity and you're trying to augment that. And I think the question there is always, if you have a drug, one drug that works 25% and you have another drug that works 25% of the time, when you give them together, do you get more than 50% activity or not? Because that's where we would start to get to a place that we would think that the combination is perhaps more active than giving the drugs one at a time in a sequence. And really that comes back to me for the idea around combination therapy. And I think that that's something to really think through if you or a loved one are thinking about clinical trials and combinations of novel agents. What's the biology? What's the rationale that these are the right drugs being given together? That said, any clinical trial that's being done has gone through registration with the FDA, has been, through IRB review boards, and those are all the questions that our internal processes and the FDA are asking to make sure that the studies aren't being done just randomly, that there is that rigorous underlying rationale for those combinations. And then, there are some more established, I think, promising combinations that are further along in development. And those really relate more to the combination of immunotherapy and with chemotherapy. And I think Dr. Mansfield is going to cover that for us.
And I'll pull my slides up again. Thank you, Dr. Zouder. I'll take over the combination talk and talk about the applications of immunotherapy with chemotherapy and surgery just for a few slides before we open it up for questions. And as Dr. Zouder was mentioning, the big question is, are the parts greater, is the sum greater than the parts, so to speak? And we are now exploring combining immunotherapy with chemotherapies in mesothelioma. As we've both said, we are a thoracic oncologist, so we also see patients with lung cancer. And in that setting, for the non-small cell lung cancers and the small cell lung cancers, we've done the large randomized phase 3 trials to prove for those tumor types that combining chemotherapy with immunotherapy is superior to what was our standard of care chemotherapy alone. And at this point for mesothelioma, there have been a few smaller phase 2 trials that were not randomized, but where patients received chemotherapy with one of these types of immunotherapy antibody drugs that we have been talking about. The two that have been published so far used a PD-L1 inhibitor called durvalumab, and the response rates and the survival outcomes in those trials are better than what we have seen historically. But we have not proven in a randomized fashion like we have in Checkmate 743 whether adding these 3 drugs together are better than chemotherapy or not. So this is an area of active investigation where there are clinical trials around the world that are open. Some have met accrual, but others are still accruing, where we are trying to answer this question. So right now I could tell you that the earlier phase clinical trials have promise. and that there are ongoing trials where we hope to see success with this combination, as we have for these other subtypes of lung cancer that I've mentioned. But this is an area of active investigation. So there's more to come, and we'll be hearing more about this in the near future. Shannon did ask me to plug trials that we have open, and the trials I'm going to mention here and then with surgery are not limited to Mayo Clinic. These are opening around the country. We do have cooperative groups in cancer, and through these cooperative groups in conjunction with our National Cancer Institute, these trials can open around the country and sometimes also in Canada. And most of what we've been talking about is mesothelioma of the pleura in the chest. And but there is a subset of mesothelioma that does occur in the belly called peritoneal mesothelioma, and unfortunately, it's understudied. We often extrapolate data from the mesothelioma of the chest to learn how to treat that in the belly. And what I have to say is there's a clinical trial that opened last year for peritoneal mesothelioma, patients with peritoneal mesothelioma. And on this next slide, you'll see once patients are diagnosed with this, they are then randomized to receive chemotherapy with that vascular drug, that VEGF drug, bevacizumab, and then they will either receive immunotherapy or not with that triplet combination. Now, for this study, some patients will be surgical candidates and some will not be, but since this is a rare disease with only a few hundred cases a year in the United States, we decided to include them both. So this is a study where roughly 30 sites have activated it, and another 35 are going through the steps to activate it in the near future. So the hope is come April or May, about 70 sites around the country will have this active. Right now it's heavy in the Midwest and a little bit in the East Coast, but in just a few months that will change and it'll be more broadly distributed around the country for patients with newly diagnosed peritoneal mesothelioma to consider to participate in. Now, the next thing I was asked to discuss is whether discuss the combination of immunotherapy with surgery. And similar to what I said about lung cancer with immunotherapy and chemotherapy, we've had a recent practice change in lung cancer where when we give immunotherapy and chemotherapy before surgery, we've seen that it improves outcomes for patients with limited stages of disease. So that's been a big practice change for non-small cell lung cancer. And we're starting to explore this more and more in mesothelioma. I would argue that it's only a subset of patients with mesothelioma who are candidates for surgery, and this is something that requires discussion with the medical oncologist, the thoracic surgeons, to determine whether someone should go to surgery or not. So it's not an easy upfront answer to say that everyone should consider this. That the surgeries for mesothelioma are intense to say the least, but now that we do have immunotherapies for mesothelioma, some studies have been done and many others are ongoing where we're now testing giving immunotherapy by itself or immunotherapy and chemotherapy, like similar to how we do it for non-small cell lung cancer, and then for those patients to undergo surgery to try to remove as much of the mesothelioma as possible. Dr. Zauderer mentioned Dr. Rimner's study, who also incorporates radiation after the sequence of treatment modalities. What I can say so far for mesotheliomas, Dr. Ann So ran a study through one of our cancer cooperative groups called SWOG, the Southwest Oncology Group, and those patients received chemo and immunotherapy together. But unlike the non-small cell lung cancer setting, many of those patients were not able to proceed to surgery, that there was a higher dropout rate than expected. And that just speaks to the differences of mesothelioma from lung cancer. And these were patients who were otherwise fit and eligible for a clinical trial. And yet a fairly large fraction of them were not able to make it to surgery, either because the mesothelioma did not respond to the treatment or they had some side effects from the treatment itself. So this is an area that's still being explored. Like I said, there are clinical trials around the country that are exploring this. And again, Shannon asked me to share trials that are active or opening. So one that is just approved by the National Cancer Institute, again through the Alliance Cooperative Group, it's going to start to activate at centers. So this study's not open at any cancer center right now because it was just approved by the National Cancer Institute a few weeks ago, and institutions are now going through the motions to activate this. But when you think back to that slide I showed you with the different histologies, patients with that sarcomatoid mesothelioma typically are not offered surgery because of the usual poor outcomes with the systemic therapies we have and the high rates of recurrence. I think Checkmate 743 really changed our thinking of sarcomatoid mesotheliomas, or the non-epithelioid groups, as their outcomes with immunotherapy are getting much closer to that of the patients with epithelioid disease. And because of that, we think that the patients with the smaller tumor burdens of sarcomatoid mesothelioma should be considered for surgery. Now, this is something we're testing. We're not saying this should be the standard of care, but we have a clinical trial that will hopefully start opening at cancer centers across the country in the next few months, where patients who are diagnosed with sarcomatoid mesothelioma, but a limited amount of it, would then receive immunotherapy as per the standard of care from Checkmate 743, and were that to control their disease and they don't have any toxicities, they would then be able to proceed with surgery, and we would determine whether this is improving their outcomes or not. So with that, I'll stop sharing my slides here. Thank you.
Thank you both so much. That was wonderful and really, really great information. I'm going to open this up now for the question and answers. We did have a fair amount of questions that came in with people's registration, so I do apologize if we don't get to everybody's. You can always please get in touch with me, and I can try and get some answers for you to your questions if we don't hit upon them today. I'm going to start with Dr. Mansfield because of the Checkmate 743. And I'm wondering, I've had several patients that have asked, is there any long-term data that exists on the benefits of the combination immunotherapy after somebody has completed the 2 years, or if they've made it to the 2 years?
So the clinical trial investigators who participated are the authors of the study. There have been 2 publications. One was the initial publication around 2020 in Lancet, which was the initial survival analysis. And then last year in Annals of Oncology, the more mature data with a median follow-up of roughly around 3 years were published. And at that analysis, the survival benefit of immunotherapy over chemotherapy was maintained. So we still continue to see a difference, but we don't have a 4 or 5 year survival analysis yet. So I imagine we will have those data in the near future, and imagine it'll be published. But right now, the 3 year mature data are what's out there, and I haven't seen anything more mature than that to share here today.
Thank you. And Dr. Zotter, for you, can you explain the role of PD-L1 testing? And at this point, does that have any influence on the effectiveness of immunotherapy in mesothelioma? Do we know that?
It's a good question without an easy answer. So, you know, what we've seen is PD-L1 testing can be very heterogeneous in mesothelioma. And that means that, like anything else, it's a function of the piece you get. And again, lots of analogies, but if you, let's say, biopsy an American flag and you get only red, you don't know that there's stars and stripes and all of these other things because the piece you actually got was just this tiny fragment and not necessarily representative of the whole. So we always take the PD-L1 level expression with a grain of salt. But in the Checkmate 743 trial that Dr. Mansfield's been talking about, certainly amongst the people whose tumors expressed it, there was more of them, there was a higher percentage that responded favorably to immunotherapy. So The challenge is when we use a biomarker like this to help us, we want it to be very powerful, right? We don't want it to just be that, well, if you're positive, 10% more likely that you're going to respond. We want it to be, if you have the biomarker, it's like 80+% likely that it's going to work. And if you don't have it, it's, 10% that it would have worked. We want it to be really differentiating. And it isn't, at least not as of yet. PD-L1 hasn't been shown to be that powerful. So in my own clinical practice, I think, as Dr. Mansfield explained, it's a slam dunk that ipilimumab and nivolumab are the right treatment for sarcomatoid and biphasic histologies. I think where it starts to maybe influence some of the thinking is with epithelioid disease. Epithelioid disease is very much an individualized, decision that I make together with my patients, thinking about side effect profiles, burden of disease, time to response. One of the things we didn't really talk about yet was that, especially amongst the epithelioid patients, the short-term progression sort of graphing is better with chemo than immunotherapy, but then the lines cross longer term. So what does that mean? Well, it means you might have to tolerate disease continuing to grow a little bit while you're waiting for your immunotherapy to kick in. In 6-12 months, you might be better off for it, but you have to get through those first few months to that benefit. And so that, along with the PD-L1 expression level, I think all factors into it. I would say also, the numbers are not sort of evenly distributed. So you tend to see a lot of people who are negative, a lot of people who have modest expression, and then a few who have very high expression. But nobody has, I won't say nobody, but not too many folks have 50% expression. You're either 0, 20, or 90. Now, maybe that's an artifact of how it's calculated, but typically it's not so compelling in these decisions. Sorry, that's a complicated answer, but it doesn't have a straightforward answer.
I feel like a lot of these don't have straightforward answers. We're just on the cusp of getting to hopefully have some more answers for these questions. Dr. Mansfield, can you explain the rationale behind the use of the combination immunotherapy for 2 years and why that cutoff happens and kind of what happens after that cutoff?
So I think the 2-year cutoff is somewhat arbitrary. When these clinical trials are being designed, we have to give some thought as to how long are we going to do the therapy. Is it lifelong, indeterminate, or is it for an interval of treatment? I would say prior to this, it was rare that someone would get 2 years of therapy. So at least in lung cancer, we have a little more mature data because those trials were done first, where some patients had 2 years of immunotherapy. They then took a break, and some of them have had very long, durable control of their disease. And then if or when it came back or started growing again, many of them responded to repeat immunotherapy, where it was reintroduced. So we've seen those data for lung cancer, and we just don't have it yet for mesothelioma. But part of giving these drugs to the immune system is you're retraining the immune system to attack the tumor. So even after you've stopped giving these antibodies, it's thought that there's a term we use of a pharmacodynamic half-life. We still think they work for a long time, even after the last dose, which is something on the flip side of that coin we also see with the toxicity. If we don't do things to intervene, those toxicities can also last a long time after the last dose of the drug, whereas with the chemotherapies, they resolve more quickly. So that it was a time point that was chosen for the design of the trial. Maybe it had been modeled a little bit after lung cancer, as we had those trials ongoing at the time, and that was the cutoff they had used. But for patients who have a great benefit for 2 years, and then subsequent to that, they get a break where they don't need to come in every few weeks and be seen. So in terms of just the burden of time and finances to come in and see us all the time, I see it as a positive thing that we might not need to give something continuously to provide a benefit. So, but I do think it was partially arbitrary.
Thank you.
And
And
Shannon,
go ahead.
I'm sorry, can
Absolutely.
I just add something to that? You know, I think it's also an actively, as Dr. Mansfield was saying, an active question. I think there's a lot of preclinical data, so data from cells and animals suggesting that you may not even need the 2 years, that there's certain point at which you get enough therapy, you're responding, and you don't need ongoing drug infusion, or at least not necessarily both drugs, to kind of maintain that response. And the other thing I think that's related to what happens to after the 2 years are like the people who stop before the 2 years because of toxicity. And they can actually often maintain their response in the absence of the drugs when you've stopped it for some kind of complication. So I think that there's so much research going on and looking at what the optimal sort of priming before priming too far that you have toxicity. So, you know, 2 years, I think, agree completely may be arbitrary. It may be the right answer is potentially less for some people. But again, we don't have that marker, that test to say, we've maximally, you know, uncloaked your cells and now your body either is going to respond or not. You know, we just don't have that ability yet.
Kind of playing off of a bit of what Dr. Mansfield was talking about, but Dr. Zotter, if someone receives combination immunotherapy, they complete their therapy line, and at some point they have progression of disease, would a different immunotherapy possibly be considered, either on a clinical trial, or would you maybe even go back to using the combination immunotherapy?
Yes, I think everything's on the table in that situation because we just don't know. I think the situations where I wouldn't go back to immunotherapy necessarily or the same is if there were toxicity and that was the reason for stopping as opposed to the time point or cut off. There's also, you know, increasingly data about, you know, whether if you get just nivolumab or just pembrolizumab and it can adding the CTLA-4 drug salvage that situation. So there's a lot of data about sort of how to do it, when to do it. I think it's always a question and an individualized conversation, what the spectrum of options are, what the risk tolerance is, and what the tolerance of the medication was the first time. And I think, you know, as time goes on, we'll have more data to inform these choices. But right now, it's sort of anything goes a little bit.
Dr. Mansfield, for you, can you explain what a cycle of the combination immunotherapy looks like? And are there different ways to give that combination?
So the way the FDA approved ipilimumab and nivolumab, it's a little tricky with the two drugs. So typically we start with the two, both ipilimumab and nivolumab. 3 weeks later, we just give nivolumab, the PD-1 inhibitor, and then 3 weeks after that, we give the two drugs again. So it's this 2-1-2-1. Sometimes there's toxicity, and it's hard to separate out if it was one or the other because they have, you know, nearly identical side effect profiles. So I often find if there is something going wrong, I have to stop them both. It's hard for me to tease out that it was one or the other. And then based on the severity of that and how quickly it recovers, we may resume a therapy. And sometimes I just start with one drug before I work the two back in. It really depends on what happened. And I'm really just trying to cautiously reintroduce the immunotherapies, but I think most people give them on this 3-week cycle, even though in the trial it was done a little differently. The dosing and the frequency or the timing of the dosing was studied a little bit differently, but the FDA has allowed a pharmacokinetic modeling of antibodies and the data we have from that to provide more convenient dosing schedules for patients. So I would argue that the approved dosing is more convenient, and we're seeing similar success as we did with this clinical trial. So a 3-week regimen, but it alternates what drugs you get with each one. And I think you also asked, are there other routes of administration? And right now for these antibodies, it's all intravenous. Some other antibody therapies have been converted to subcutaneous forms, but to my knowledge, that has not been done with these two or pembrolizumab, and maybe it's being explored, but I'm just not aware of that.
Thank you. Dr. Zotter, for you, can you discuss some of the side effects, some of the larger side effects that we see from immunotherapy, and what is the treatment for them?
So pretty much any body part, we can slap itis onto the end of it and say that it's inflamed. That's all it means. Arthritis, arth is joint, itis, inflammation. The ones that we really worry about are inflammation in the lung, which is called pneumonitis, inflammation in the colon, which is called colitis. Those are the ones that can be sort of potentially life-threatening in a short amount of time. Other things that happen, though, is the glands can get inflamed, and so you can have dysfunction of the thyroid gland. You can have dysfunction of the pancreas, of the adrenals. You can very, very rarely have inflammation around the spinal fluid. Typically, whatever it is, the treatment is to try to suppress the immune system. And the goal of that treatment is to really suppress the immune system as quickly and as effectively as possible, but also with an eye towards trying to get people off the immune suppression as quickly as possible. So you don't want to undertreat it, but you don't want to overtreat it and in some way potentially interfere with any anti-cancer activity that the immune system is doing. So it becomes a very kind of complicated tightrope. And, you know, I'm sure this is the same for Dr. Mansfield, but we work very closely with our colleagues in the other subspecialties, so the gastroenterologist, the pulmonologist, the endocrinologist, to really figure out the best treatment. Usually the initial therapy is some form of prednisone, whether it's a pill form, an intravenous variation on it. Increasingly, though, there are other types of steroids, like something called budesonide, which is an oral steroid that is not absorbed into the bloodstream. And the idea there is that it can sometimes treat the colitis without really getting into the circulation system with any significance. But, you know, those are all sort of very complicated nuances. And then the sort of next class after steroids are some of the immune modulating drugs that are used to treat symptoms and problems in people who have autoimmune diseases. So people who have ulcerative colitis or Crohn's disease, rheumatoid arthritis, and they get treatments to suppress that excessive immune response to their own body. Sometimes we use those medicines to treat cases that are requiring either very long-term steroids, and we're trying to get people off the steroids, and or people who aren't responding vigorously enough to the steroids. We'll give these other immune modulating treatments.
Thank you. Actually, that leads right into my next question. Dr. Mansfield, somebody who has autoimmune disease or a history of autoimmune disease, can they safely be given immunotherapy, or would that be completely off the table?
So were they to try to go on a clinical trial, most trials would exclude them from participating. There are some exceptions for hypothyroidism, but the majority of the clinical trials out there with these immune checkpoint inhibitors would say, no, you cannot participate. That being said, the National Cancer Institute has sponsored a trial for patients with autoimmune conditions to receive immunotherapy and then to track how often do these conditions flare or come back. People have published case series on this, and the rates are high. So based on the autoimmune condition and the cancer we're dealing with and talking about, it's a difficult decision and discussion to have as to whether we should take those risks, because the odds are that that condition will worsen with the immune checkpoint inhibitors. But more often than not, it will. And then that also comes up with organ transplants, and so you're likely to lose that graft. So there's these are very difficult decisions to make. But for a clinical trial, except for the trials that are specifically studying this, it's unlikely you'd be able to participate outside of the clinical trial setting. Again, very difficult, and we just we've done it. We've worked really closely with our colleagues in those other medical subspecialties like rheumatology or gastroenterology, and we try to come up with a management plan and monitor these patients more closely when there's no other great systemic therapy options, and you're dealing with these two conditions. So it's a very challenging situation.
Thank you. Dr. Zotter, I'm going to sort of go back to the side effect issue, but if you have somebody who is on immunotherapy and it is successfully treating the mesothelioma, and they do start to show some side effects, at what point do you stop the therapy because of the toxicities? Is there a level of that?
That's a great question, and one that I think is probably understudied, just because of challenges of how to do it. If I have someone who needs steroids to treat a complication, then this is part of a conversation about what the risk, benefit, and alternatives are. If you reach the point, though, of having a side effect that requires steroid therapy as a complication of your treatment, and you haven't yet responded, more immunotherapy, the data from all the other diseases where we use immunotherapy is pretty compelling that at that point, more immunotherapy just leads to more toxicity, not more chance of a response. So I do sort of think in those first few months, if it's not helping and you have terrible colitis or something like that, that's when the drugs get discontinued for sure. If you're responding and you have a side effect that requires steroids, what I will often do, depending on the severity of that side effect, is have a very sort of nuanced conversation about whether someone can just be observed, meaning that you're not getting more immunotherapy, but we get you off the steroids or the immunomodulating drug. So it's almost like your immune system can kind of coast in that delicate in between, where I'm afraid maybe more immunotherapy would cause more side effects and have to be on immunosuppression, and that balancing act. Sometimes there are situations where we also modify the regimen, but as Dr. Mansfield said, other than probably colitis, which is most often associated with the ipilimumab, but could be from both, it's very hard to tell which drug is causing a side effect. But I definitely also have patients where we sort of cautiously restart one drug alone, usually the nivolumab, and see how that goes. I think the sort of more interesting question that I struggle with is when someone side effect yet that requires steroids, but they're trending toward that. Is there any justification for just stopping before you get to that point of needing steroids, and observing versus sort of pushing ahead and getting to that place of having that severe toxicity? And that implies that we can see it. I think a lot of times these side effects go from 0 to 60 like that. You don't have them, and 2 days later you do have them. So they're hard to predict. I do have lots of people in my own practice, again, this is not data, but personal experience, who have come off treatment for some toxicity and haven't gotten other treatment because their cancer, while not gone, is quiet. And I followed people like that for very long periods of time. And so it's a very hard judgment call, and has a lot to do with the severity of the side effect, what alternative options there might be, and sort of the person, whose life it is, what their sort of outlook and risk tolerance. And it comes from sort of knowing people and having those relationships with them to try to make the best decision together.
Thank you. Dr. Mansfield, I'm going to ask a little bit about neoadjuvant and adjuvant, but is there any support or any sort of trial that are looking at giving chemotherapy up front, followed by potentially surgery, and then followed by immunotherapy on the back end?
I'm not aware of a trial separating out the chemoimmunotherapy that way. I think most of the studies are doing the immuno up front or the chemoimmuno up front, followed by surgery. So I get the question, but I'm just not aware of any study designed that way.
Thank you.
Can I just, sorry, I just want to say one thing about that. Sorry to interrupt. There was actually a really fascinating study just reported in melanoma, different cancer, but that's where immunotherapy started. And it looked at people, I think, getting 15 doses of immunotherapy. And it was you had surgery and then got 15 doses, or you got 3 doses, got surgery, and then got 12. And the people who got the split, who got some before, did remarkably better. Wow. And I think that is like very provocative for those of us who are thinking about how we should design these trials and think about it. And again, it's not from mesothelioma. We can't say that applies, but there's an increasing evidence in the cancer literature that potentially getting the immunotherapy while the tumor is still there may matter. And so I think that's something that we're all talking about and thinking about behind the scenes.
That's exciting news, actually. Dr. Mansfield, so another question for you would be, if you have a patient who has gotten first-line immunotherapy, they do have progression of disease while on therapy, what would then be your second-line treatment plan? Or is there guidelines for a second-line treatment plan?
Well, yeah, it's hard to just give a blanket answer to that. It depends on how they did with the immunotherapy, what other conditions, the medical conditions a patient may have, and their current status. So not everyone gets to a second line of therapy. Of those who do, I then go back to that platinum pemetrexed with or without bevacizumab regimen at that point. We also consider clinical trials if we have ones that are open and that patient might be eligible for. So it really depends on all those features. What's that patient status? What other medical conditions do they have? Do they want more treatment or not? If it's not on a trial basis, I am then going back to a platinum pemetrexed regimen though.
Thank you. And Dr. Zotter, I think kind of the last question here, and we'll start wrapping things up. We want to be certainly mindful of you guys' time with us today. As far as peritoneal goes, because we are sort of understudied in that, and we do have the trial out looking at the combination of immunotherapy and chemotherapy, but do we know any data for peritoneal when you're looking at treating somebody with immunotherapy versus chemotherapy?
So there's hasn't been any head-to-head comparison. There is some data around the use of one of the immunotherapies called atezolizumab, given in combination with bevacizumab, that VEGF inhibitor we've been talking about a bit. And there's some data to support using that regimen. There was also recently a pooled retrospective analysis that we did along with the team at the University of Pennsylvania, looking at the use of pembrolizumab in peritoneal mesothelioma. Again, not head-to-head, retrospective, meaning looking back instead of looking forward, but still in this space, some of the data. I think we'll know a lot more from Aaron Mansfield's trial that's going through the cooperative groups. And I think that there's just so many open questions in peritoneal and variables. You know, there's another trial, multi-center, called Icarus, that's launching, that's looking at, you know, high PEC versus IV versus intraperitoneal after you know, there's so many questions, you know, about just how to give the chemo in this optimal fashion. So I think it's even harder when we layer in that immunotherapy question.
Absolutely. Well, thank you both so much for being here with us today. This has been really, really a great conversation, and I know for our patients, this is going to be such good information for them. We've answered a lot of their questions today. But again, if others have questions, and I also have everybody's submissions, certainly we can try to answer them offline if you would like to email me or get in touch with the foundation. But otherwise, thank you so much for being here today with us. We appreciate both of you and all of your time today. Thank you.
Thanks, Shannon. And thanks everyone for tuning in.
Thank you.